Today we'll talk about thoracic bony cage, and that includes the bones, the soft tissues, mostly the bones. When we say cage, it's mostly the strong bones that cover and protect the lungs and the heart. There are several, apart from local disorders like congenital, say bifurcation of the rib, or even say absence of a part of the clavicle, or even infections, local infections, trauma. Apart from that, today we'll focus upon systemic disorders that reflect upon the thoracic cage. Maybe focal, for example, say metastasis, maybe single metastasis in the ribs or sternum or clavicles. Or it may be multifocal, multiple lesions involving the bones of the thoracic cage. What are the various systemic disorders? There must be a classification for the systemic disorders in order to progress in our talk. For example, congenital or even developmental, inflammatory like eosinophil granuloma, sarcoidosis, infections, viral, bacterial, fungal, spirochetal, parasitic, and then hemopoietic disorders, either benign or malignant like leukemia, lymphoma, etc. Metabolic disorders, both nutritional and otherwise, neoplasms, benign neoplasms, malignant neoplasms, and then miscellaneous causes. Congenital, let us take bone dysplasias. In bone dysplasias, for radiological purposes, we can divide them into dense sclerotic lesions, lucent lytic lesions, or mixed lesions, both sclerotic as well as lytic. Diffuse increase, homogeneous increase in bone density. Classical example is marble bone disease or osteoporosis. Next comes pycnodisostosis, then myelosclerosis, idiopathic myelosclerosis, mastocytosis, Engelmann's disease, so-called diaphyseal dysplasia, or idiopathic hypercalcemia, which includes Williams syndrome with pulmonary stenosis, etc. Osteoporosis or marble bone disease is diffuse sclerosis of the bones. Sometimes you may get an inset, a bone in a bone, that is the primitive bone and then the developed bone. It involves all the bones, ribs, scapula, clavicles, spine uniformly. And then next comes the pycnodisostosis. There is osteosclerosis, but there is hypoplasia of the clavicles, which you do not find in marble bone disease. So in a radiograph of the chest, if you see hypoplasia of the clavicles, although there is diffuse density of the bones, still you have to diagnose as pycnodisostosis. Anterior notching of the vertebra. If there is a thoracic spine, there will be anterior notching of the thoracic vertebra. Now look at the chest film. There is dysplastic or hypoplastic clavicles, both bilaterally. There is not uniform mineralization or ossification. And then if you look at the thoracic spine, the anterior notching is there. Then comes Piles disease, or the so-called metaphyseal dysplasia. Widened medial ends of the clavicles, because the metaphyses only are involved. And look at the posterior ends of the ribs here, widened, which you may get in other conditions also. For example, Cooley's anemia, you may get that widening, but this is congenital. And also note the clavicles, the metaphyses, although they are extending to the diaphysis, they are widened, metaphyseal dysplasia and sclerosis. And then comes the idiopathic hypercalcemia, or so-called Williams syndrome, where you get a elephant type of facies clinically, and then radiologically you may get pulmonary stenosis, but the most important thing is sclerosis of the bones. Then an important entity called fibrous dysplasia. Fibrous dysplasia is fibrous aberration of the ossifying regions of the thorax or entire body skeleton. It could be monostotic, only one bone may be involved, although you may do a skeletal survey, still There is only one bone that may be involved, or polyostotic, multiple bones. And when it is polyostotic and when it is unilateral, particularly in girls with sexual precocity, you call it Albright syndrome. Predominantly unilateral, with sexual precocity in girls, and sometimes you get skin changes also. Radiologically, what do you find? Ground glass appearance of the matrix. Normally, there is a differentiation between the cortex and spongosa. That spongosa bone looks ground glass. Lytic area with a rind and smoky, same as ground glass type of matrix. Occasionally, you may get a calcific matrix, which resembles cartilaginous calcification. And then you may call it a fibrochondrodysplasia. And then, when it is aggressive, it may balloon the bone and then it thins out the cortex. And in some cases, you may get a diffuse density or mixed osteolysis as well as dense sclerosis. Look at the cone view of the left upper chest. Look at the first and second ribs. They are expanded as though there is an aneurysmal bone cyst. And if you look at the matrix, there is ground glass appearance. To the unwary, if you look at the chest, you may think it is a lung lesion or pleural lesion. But you look carefully, the ribs are involved in this case. Another oblique view of the left fourth rib, diffuse lobulated expansion of the rib, which does not occur in any of the other lesions. In aneurysmal bone cyst, it is localized and it doesn't have a matrix which is smoky or ground glass. And then hypoplastic type of thorax, a small thorax, that you can get in asphyxiating thoracic dysplasia. Usually the children do not survive for long. Ellis-Van Creveld syndrome, there also there is a small thorax, but there are other anomalies like ASD, VSD, the heart, skeletal anomalies, particularly the hands are typical, polydactyly, syndactyly, syncarpus. These are some of the clinical as well as radiological features in Ellis-Van Creveld syndrome, or you call it chondroectodermal dysplasia. Short rib polydactyly syndrome. Short ribs are may be present. This also, the children do not survive for long. Asphyxiating thoracic dystrophy. Look at the narrow thorax. As I said earlier, these children do not survive for long. Short ribs. Achondroplasia, which is a common dwarf that we see day in and day out, and you find the spinal canal, as you come down from the lower thoracic to the lumbosacral area, their interpedicular distance is narrow, narrow spinal canal. Normally, it should be like an inverted funnel, but whereas here, the narrow spinal canal, you could see, of course, apart from the dumbbell type of tubular bones, bladed iliac wings, etc. Miscellaneous syndromes, craniocledodysplasia or cledocranial dysplasia, delay in ossification centers. You remember we have talked about pycnodisostosis, where there is dysplasia or complete or incomplete absence of the clavicles. Same thing we can get in cledocranial dysplasia. And in addition to this, you may get midline defects in craniocledodysplasia and of course vermian bones. Vermian bones you can also get in pycnodisostosis. Then spondyloepiphyseal dysplasia, again it is congenital, ovoid type of vertebra, dorsal wedging, dislocation of C1, C2, which you can get in other syndromes like Downs, etc., retarded ossification of the epiphysis. Look at the vertebral bodies. They are flattened, marked platyspondyle, and there is anterior beaking. This you can get in several conditions also. Platyspondyle, spondylometaphyseal dysplasia. This is, one has to distinguish between spondyloepiphyseal dysplasia and spondylometaphyseal dysplasia. Here there is no beaking, all flat type of vertebrae because the apophyses are involved. Then we come to the mucopolysaccharide disorders. There are 7 types of disorders in this, but the important ones are Hurler, Marquio, and as I said, 4 or 5 others are noted, mucolipidosis also. We were talking about vertebral beaking. Inferior beaking, you can get in Hurler syndrome, cretinism, hypothyroidism, achondroplasia, diastrophic dwarfism, and trisomy 21. Whereas central beaking you can get in Marquio syndrome, achondroplasia again, spondyloepiphyseal dysplasia, which you have seen earlier, and occasionally it may be normal from say 6 to 8 years in a child. Talking about thoracic cage, and again we come back to generalized increased bone density, acquired. Earlier we said congenital or developmental, now this is acquired. Renal osteodystrophy, where there is osteosclerosis, and other changes like hyperparathyroidism, etc. Hypoparathyroidism, fluorosis, toxic doses of fluorine in the water, endemic areas, you may get diffuse sclerosis of the bones besides ligamentous calcification. Hypervitaminosis A and D, either inadvertently or by the over-enthusiastic mothers, they may give lots of doses of A and D, cod liver oil, etc. Metastases like prostate, breast, lymphoma, Paget disease, which is rather rare in India, but still diffuse sclerosis you can get the same as you get in Western countries patients. Sclerosing myeloma, Poem syndrome. Okay. In general, 95% of the time, myeloma or deposits produce lytic changes in various bones from cranium downwards. Whereas in Poem syndrome, where there is peripheral neuropathy, organomegaly, endocrinal changes, and myeloma, all these include sclerosing myeloma. Diabetes insipidus also may be seen. Myeloid metaplasia, either primary or secondary. Sclerosis, what are the changes that you get in the skeleton? Osteosclerosis. Occasionally in the beginning, early stages, you may get osteopenia also. Calcifications of various bursae, ligaments, ossifications, osteophytes, enthesopathy, growth lines in the tubular bones, and diaphyseal widening. That means lack of modeling. Fluorosis, cervical spine and clavicles, as well as ribs, you can see diffuse sclerosis. And also note in the inferior borders of the clavicles, calcification of the ligaments. Another specimen where you see the intercostal areas, the ligaments and part of the muscular attachments are also calcified and even ossified. Another diffuse sclerosis, almost the lungs are obscured by the sclerotic thoracic cage. Similarly, another one. And again a specimen, look at the sawtooth appearance of the muscular attachments where you get calcification and even ossification in the inferior boards ribs. Now we come to oxalosis. Oxalosis, there is a primary, a genetic error, and then or occasionally you may get in secondary hyperparathyroidism, oxalosis. And what are the changes that you get? Apart from diffuse sclerosis, look at the growing ends of the bones or lateral ends of the bones. There is calcium oxalate crystals deposited. That's why it is sclerotic at that growing end of the bone. Radiological findings, coarse rarefaction, and cystic changes in metaphyses. That is another typical example. Sclerotic metaphyseal bands as I described earlier. Look at the posterior ends of the ribs. They are widened and also sclerotic. Similarly, the entire spine, vertebral bodies in a child. In the lateral view, you find diffuse sclerosis. Now we come to the entity called Osteogenesis Imperfecta congenita, imperfect osteogenesis. There are 4 types clinically, but then radiologically the common factor is osteopenia, multiple fractures, and the ribs are called expanded, thin out ribs, ribbon ribs. Note, the ribs in the oblique view, some of them are lytic, expanded, they are thin. Thinner ribbon ribs you may get in other conditions also. One, as we said earlier, Osteogenesis Imperfecta, Melnick Needles syndrome, Gorham's disappearing bone disease, neurofibromatosis, and Marfan syndrome also. You can get thin ribbon ribs. Now we come to the important entity, spondyloarthropathies, that reflect changes in the thoracic spine. Ankylosing spondylitis, it could be juvenile or adult. Psoriasis, the skin changes. Rider syndrome, spondylitis associated with inflammatory bowel disease, not only ulcerative colitis, Crohn's, dysentery, or in women, pelvic disorders, they may also produce similar changes that you see in ankylosing spondylitis. Look at the thoracic spine. In AP view, look at the thick osteophytes, as though they are fusing to each other, bridging the, but it's not bilateral, it's not symmetrical. It is a case of psoriasis. Whereas on your right side, apart from the kyphosis, smooth kyphosis, you find calcification of the anterior vertebral ligaments and also interspinous ligaments with some calcification of the intervertebral disc. This is typical of ankylosing spondylitis. Calcification of the intervertebral disc is not significant. That may occur in any immobilized spine. Now the new entity called DISH, disseminated idiopathic sclerosing hyperostosis. And when it is focal, that I described earlier, it is focal idiopathic sclerosing hyperostosis located only in the cervical spine. Here, radiologically, you get paravertebral flowing type of ossification, anterolateral at least 4. If you take the ossification is in the anterolateral area. So you have to take a lateral view in order to demonstrate. In the AP view, you may not see it that clearly. Disc spaces are preserved here as opposed to degenerative changes. Ossification separated from vertebrae. A little space is there between the ossification and the anterior vertebral margin. Ossification at extraspinal sites also, for example, ischial tuberosities, iliac crest, lumbosacral ligament, all these are also calcified in DISH. Almost from this description, you would think of fluorosis, but there is a difference between fluorosis and this. Here, there is no sclerosis of the spine, whereas in fluorosis, it is dense sclerosis of the spine or other bones. That is absent here. Lateral view of the thoracic spine, look at the flowing type of hyperostosis. Occasionally, you may get segmentally, such as you saw in psoriasis, but this process should include at least 4 or 5 vertebrae. Then only you call it DISH. And then definition of phytes. What is a phyte? Osteophyte could be marginal. In your description, you have to say marginal osteophytes or non-marginal. Paraspinal, apart from the spine. Desmophyte is thin and delicate fibrous type of lesion with calcification. And syndesmophyte, synosteophyte, this also is only syn means bridge it together. Spondylosis deformity, this is the most common, otherwise we call it degenerative aging type of degeneration of the spine. Here you may get multiple discs or a single disc disease. Marginal and non-marginal osteophytes are present, but they are asymmetrical. But there is generally no reactive bone. Small snores is another term that you have to remember. These are herniated disc material into the adjacent vertebral body. Degenerative joint disease, you can see. Osteoporosis generally. Hyperparathyroidism because of the bulge, because of the weakness of the vertebral body, you may see small snores. And Schroermann's disease often occurs in youngsters, teenagers, and with the juvenile type of kyphosis and multiple small snores. Neoplasms also occasionally, a metastasis or a primary neoplasm may push the disc material into the adjacent vertebral body. CT, plain films also show small snores with a defect in the central portion of the vertebral body. Occasionally it will be on either side, marginal also. This is typical. There are areas of sclerosis and in the center some lucencies are also there.